Hi, I'm Jared Gardner. Today we're going to talk about dermatofibromas. These are common spindle cell lesions in the skin, and not only are they common, but they have a wide variety of different patterns and kind of flavors, if you will. And so it's always good to know things that are common and have many different morphologic variants. We're going to cover some of the basic features in this video, and then I'll make additional videos that show some of the variations you can see in dermatofibroma, and also talk about how to tell dermatofibroma from dermatofibrous sarcoma protuberans, DFSP, as that's a question that often comes up. This is what you'll often see, a shaved biopsy or maybe a punch of a dermatofibroma. So you may not see the entire lesion if it's shaved, but what we can see here is a spindle cell proliferation in the dermis. Now, before you go to high power, look at low power. Low power is important in all of pathology, especially dermpath, but it's really helpful for dermatofibromas because a lot of the features that help you make the diagnosis are seen at low power. Number one, there's a spindle cell proliferation that's usually, not always, but usually centered in the dermis. And it's kind of haphazard spindle cells, and it's not smooth bordered. See, it's small, but it kind of is jagged at the edges. Let's see if I can get the arrow under control. Right out here. See, it kind of splays out in between dermal collagen, okay? I think of it, it looks like a little explosion happened in the middle of the dermis, and it sends little blast waves out to the side, okay? So that's one thing. You have this kind of little explosion of spindle cells centered in the dermis usually. It entraps collagen bundles at the periphery. We'll go down closer to see that, but even from low power, you can see these big bundles of reticular dermal collagen that are being wrapped around by the edge at the periphery of the tumor by tumor cells. Here's more. That's entrapment of collagen bundles, a really useful clue for dermatofibroma. Look at the epidermis. This is the patient's normal epidermis way out here. You can see the reedy ridges. As you get closer to the center overlying the dermatofibroma, the epidermis becomes acanthotic. The reedy elongate. Sometimes they fuse together like this. And also, look, the bottom of the reedy become flat. They're blunted, okay? So the reedy are elongating and they're getting flat along the bottom. So people call that tabling. My fellow Gina Johnson, a couple years ago, she liked to say tables and chairs. I'm not sure what the chairs are, but I really like that, and so I like to say that still. So this kind of tabling or tables and chairs of Gina Johnson, whatever you like, that's the pattern that you often see. So this is a kind of what we call the induction phenomena, that the epidermis is induced to kind of grow in a reactive manner because of the underlying dermatofibroma. And particularly we call it induction when you see adnexal differentiation up here in the epidermis, which I'll show you later in this video. So the other thing that people like to point out is that there's often a Grenz zone. A Grenz is this layer of relatively uninvolved dermis between the epidermis and the tumor. And it can be seen in dermatofibromas and granuloma faciale and a variety of different entities in dermatopathology. I personally do not find the Grenz to be a very helpful concept for most things in dermpath. For me, maybe it works for you, but for me, I feel like it's not that helpful of a feature, and I feel like it's not always there when it's supposed to be. So for example, when DFs get picked at by the patient and irritated, I feel like the Grenz zone disappears and the dermatofibroma pushes way up into the epidermis and is right smack below the epidermis. So anyway, you'll hear people talk about a Grenz. If that concept works for you to help learn this lesion, then awesome. Okay, now the one other thing, that's I guess all for now from low power. I think that's all we can extract here at low power. Now, after we've seen that, on a test, that's dermatofibroma until proven otherwise, and in real life. Then you can go to higher power if you want to confirm it, okay? The reason you gotta be a little careful about higher power is sometimes dermatofibromas have big cells, atypical cells, patterns that can kind of concern you. So here's an example of kind of a swirling, whirling, almost story-form pattern. A story-form is the buzzword for dermatofibrous sarcoma protuberans, but we actually see it on a regular basis in dermatofibromas. So don't be concerned about that. Sometimes the cells are swirling or story-form. Sometimes they're haphazard. In cellular dermatofibromas, you can actually have cellular fascicles of spindle cells. So there's a lot of variation here that's possible. Let's look out at the edge. Here are these thick bundles of pink collagen, and you can see they're being wrapped and kind of entrapped within the tumor. Look at that. The spindle cells are wrapping around these dense bundles of pink collagen, a very classic feature of dermatofibroma, okay? In the middle, we showed those cells, and let's go a little closer. The cytologic features of the cells of dermatofibroma are usually they're kind of plump spindle cells with variable size and shape. So they don't all look uniform and really small most of the time. Again, there's lots of exceptions, but I would say most often the cells of dermatofibroma are kind of plump and enlarged, and some of them are bigger than others. There's, if you will, even a mild degree of pleomorphism. Sometimes there can be really big pleomorphic cells scattered in the midst of a dermatofibroma. People call those monster cells, if you like that name. So the reason I point out the cytology is that dermatofibrosarcoma protuberans, DFSP, usually does not have large plump cells of varying size. It's a translocation sarcoma, so it has very thin, stretched out, attenuated spindle cells that all look like each other most of the time. Okay, so I'm going to do a whole other video on DFSP, and we'll talk about that in great detail at that point. And I'll put a link down below in the comments or the video description once I have that video ready. So anyway, in the cytologic features, expect the cells to be a little more plump and to have some variable size and shape in dermatofibroma. And here's a closer look at the epidermis. You can see again the rete are elongated. There's flattened tabling along the bottom of the rete. And another feature, a lot of times the basal layer becomes hyperpigmented. And yeah, there are some rare melanocytes here, but really this is just increased melanin within the keratinocytes, okay? So this is basal keratinocyte hyperpigmentation, almost like what you'd see in a seborrheic keratosis or a lentigo. And this is why dermatofibromas often look brown or pigmented clinically, and I often see them biopsied, and the clinical differential includes rule out seborrheic keratosis or rule out nevus because they look pigmented. All right, so keep that in mind that they can be pigmented, and in fact, it's a common finding actually. All right, so that's a classic example. Let's look at a few more to get an idea of kind of the variation that we can have here. So here's a punch biopsy, okay? So we can't see the periphery of the lesion very well, but we can see the base of the lesion. Note again right away, you can see the epidermis is acanthotic. There's really thickened, elongated rete ridges, and there's again that flattening or tabling at the base of the rete as it kind of, I feel like the tumor puts out a force field, and the rete grow down and they hit that invisible force field and then stop growing and kind of squish up against it. That's the way I like to think of it, okay? Again, haphazard spindle cells kind of filling up the dermis here. If you go to the periphery of the tumor, you can see a little of the periphery down here at the base. You can see entrapped collagen bundles. There's the entrapped collagen. You can see a little bit more of it over here. Some entrapped collagen. And in the middle of the lesion, the cells look relatively similar to what we saw in the last case. Spindle cells, some of them are plump, and they're kind of admixed with collagen, small collagen bundles here, and arranged in a kind of a haphazard or maybe a little bit storiform manner. And here's the other side of the same lesion. Okay. Here's an example that's more, not quite polypoid, but almost pedunculated. It's kind of a sessile polypoid. I guess it's flat based but bulging up. At the top, you can see that the top of the lesion is flat. Not only are the rete elongated and blunted at the bottom here, you can see over there again the nice tabling, but look at the top of the lesion. I wish I could go to a lower power, but this is the lowest power I have. This is kind of a flat-topped papule, and sometimes clinically the dermatofibromas, when they bulge out of the skin, will have that shape. And this is just a nice example of how much of the epidermal change you can have. Sometimes it can almost have a verrucous or warty sort of appearance at the edges. And this one is a lot more fibrotic or collagenous than the other ones I showed. There's a lot more dense collagen in this one here. So there are a lot of collagen bundles, so it looks very pink. But it still has those spindle cells in there intervening in between the collagen, all right? But again, if I just showed you one picture of this, you might have trouble coming up with the idea that this is a dermatofibroma. So that's why I think the real helpful feature is starting at the low power and seeing all those clues, the collagen entrapment, the epidermal hyperplasia, et cetera, et cetera. Here's an even more dramatic example. Look at how thick, if you just had a shave biopsy through the top of that, you could call it a wart. You might think it's the top of a seb or a prurigo nodule. You might think it's a keratotic lesion. It's only once you see the dermis that you realize what you're dealing with is the top of a dermatofibroma. So occasionally if I get a shave where I can't really see the dermatofibroma, but I see epidermal changes like acanthosis or tabling of rete that make me wonder if there could be an underlying dermatofibroma, sometimes then I'll say epidermal hyperplasia with a comment that that, this could maybe be a seborrheic keratosis or something, but also this could be hyperplasia overlying a deeper unsampled dermatofibroma. And it's benign either way, but I like to do that in case the lesion persists and there's still a firm bump there. The dermatologist knows that way, oh, maybe there's a dermatofibroma under here. So occasionally that happens on a small shave where you can't see the base. But in this case, we see the epidermal change, and then under it you can see this spindle cell proliferation that's replacing the normal dermal collagen. It's kind of exploding and pushing all the regular collagen out of the way. And again, at the edge of the lesion where it interfaces with the normal dermis, we can see nice thick pink collagen bundles that are wrapped and entrapped by the tumor cells. And let's get a closer look here again to see if we can really see the cells actually. I think maybe we'll see it in another case better. But the cells really do, these plump cells, these are the dermatofibroma cells, these plump guys here, they really do try to aggregate and wrap around each collagen bundle at the periphery of the tumor. So a good example of collagen entrapment and prominent epidermal hyperplasia. Now, this is an old and somewhat faded slide, but I think it'll still work for us. Let me wipe it off here. Nope, no good. All right, well, it's in the dermis. There's not a lot of epidermal change in this one. You can see just a very small touch of acanthosis and blunting or tabling of the reedy ridges here. This one is centered more in the deep dermis and really kind of pushes a touch into the subcutis, which is totally fine. But the reason I'm showing this example here is look at the collagen bundles. They're very prominent. And they're really abundant. They're not just at the edge of the lesion, they're all in the midst of it. So you can see multiple large pink collagen bundles there, completely wrapped by the lesional dermatofibroma cells. Let's get a closer view. Very, very nice example of collagen trapping here, and a really good classic example of that. And on the other side, you can see this. Dermatofibromas aren't supposed to go into the fat. Yeah, actually they can. I see it on a regular basis. And so you don't want to let that little trickling into the superficial subcutis confuse you with dermatofibrosarcoma protuberans. And we'll talk more about that in a minute. But DFSP usually has extensive fat involvement with lots of fat trapping, not just like little tiny roots of tumor stretching down. You can occasionally have dermatofibromas that are centered entirely in the subcutis. I'll show you one in a minute. But in any case, know that just because there's some fat involvement, that does not mean it's DFSP. Always good to keep DFSP in your differential, but once you've watched this video and once I make the DFSP video, you will know all the features, and most of the time on H&E, you can sort those two things out. So example of some fat involvement and really nice example of keloidal collagen bundles in this dermatofibroma. Now, there's one other thing that happens only some of the time over dermatofibromas, but it's really cool and it's good to know about. It's a really helpful clue for the diagnosis if you're struggling. So here you can see the dermatofibroma in the dermis. This is a punch biopsy. Really, most of what we're seeing is the lesion. It's mostly dermatofibroma replacing the dermis here. And the epidermis has definitely got epidermal hyperplasia, elongated, reedy. The basal layer is brown. But look, what's this stuff? They're blue basaloid cells down the tips of some of the reedy. And in a way, they really kind of resemble basal cell carcinoma. Now, this is an example of what we call follicular induction. So this is where the epidermis is growing, and additionally, we get some hair follicle production. So little baby hair follicles are starting to form. For some reason, the dermatofibroma causes the epidermis to grow these follicular structures. And they can look a lot like basal cell carcinoma, but they are not. So the things that can really help you, right, for one thing, be very, very hesitant, unless you have a lot of experience, be hesitant to ever call a diagnosis of basal cell carcinoma right above a dermatofibroma. Now, I have seen a few cases of true, obvious basal cell carcinoma right above or right next to a dermatofibroma, but I would recommend that unless you've got a lot of experience, that you be very cautious before you do that, and maybe seek opinions from other people who have more experience with it. The one thing that can help you, though, microscopically, if you're trying to decide is this induction, is look at this. right underneath there, we've got basaloid cells, and then underneath we've got this little accumulation of stromal cells, see? And they're kind of pushing up and bulging into the basaloid cells. This is similar to what we see at the hair root. The hair papilla is this little cluster of mesenchymal cells that push into the bulb of matrical cells at the root of a hair follicle. And we see this same pattern recapitulated in benign follicular tumors like trichoepithelioma, where we see these little structures called papillary mesenchymal bodies. This is kind of that same phenomenon. So if you're lucky, you'll see a little bit of this little bit of round to spindled cells hugging the base of the basaloid cells is a really nice clue that you're dealing with induction. But again, on a test or in real life, most of the time, if you see something basaloid right above a dermatofibroma, it's good evidence that what you're dealing with probably is a dermatofibroma, although there are a few other things that can sometimes have that phenomenon, but usually when we see it, it's dermatofibroma. And also it's good evidence that the basaloid thing is probably benign induction phenomenon rather than true basal cell carcinoma. Now, if you see clefting with mucin, if you see basaloid stuff going way out beyond where the center of the dermatofibroma is, then you could start thinking about maybe a rare example of basal cell over a DF. But this is a real nice example not only of epidermal hyperplasia, basal layer hyperpigmentation, but also induction change. And here, let's look closer at this one. Again, those are the stromal cells. If you did a keratin stain here, all the basaloid stuff up here would stain because it's all epithelial. But these little cells, even though they look round, those are actually mesenchymal stromal cells. They're negative for keratin. So that's, again, kind of similar to that hair papilla or papillary mesenchymal body that we see in normal follicular structures and benign follicular tumors. And then here's the dermatofibroma down here. Here's another example of dermatofibroma. This one's a little more subtle because down in the dermis it almost looks like scar. It's very sclerotic, and it's got like a little nodule of dense hyalinized collagen here. So you might even wonder, how do we know it's a dermatofibroma? Okay, I'll tell you, the one thing that would help me in this case, if it was at a higher power, I'll show you one feature. Right here you can see the cells are kind of not the spindled these cells could look just like scar right here. Okay? See if I can get a different color arrow. Those cells could be scar in the right setting. But these cells here, they're kind of triangle shaped or boomerang shaped, and they're starting to wrap around tiny little bundles of collagen. So I feel like when I see triangle shaped looking cells or boomerang shaped cells wrapping around individual tiny little bundles of collagen, we see that in the early kind of atrophic form of dermatofibromas, which can be very small and very subtle. And I think that's what's going on here. This is a little tiny atrophic dermatofibroma. These little spindled and kind of boomerang cells wrapping around collagen. If I find even a little area of that, that really makes me think of dermatofibroma rather than scar, for example. From low power, you could think some of the areas like out here could be scar tissue. You could wonder about that. But again, the thing you probably noticed right away, the most helpful feature is what in the world is going on with the epidermis. That's induction phenomenon again, and that's a great evidence that what we're dealing with is not a scar, it's a dermatofibroma. And this time we see induction not only of basaloid stuff, which is of follicular origin, but also a few sebaceous glands. So sometimes you can even see sebaceous induction along with the follicle basaloid-looking cells. And that's not surprising since embryologically, sebaceous glands and hair follicles have similar, they have the same embryologic origin. Okay. Now look, this one does have a little touch of mucin over it. Look, there's a little mucin and a cleft there. But I am not going to call this a basal cell carcinoma over dermatofibroma. Look, it's got other areas that have obvious sebacites. We've got an obvious dermatofibroma right underneath it. Here's a good example of what I was talking about earlier, where you can see the individual cells swirling around individual little small bundles of collagen. Really helpful for the atrophic form of dermatofibroma. All of this stuff right in here, really good for dermatofibroma. So this is another dermatofibroma with induction, both follicular kind and sebaceous kind. And here up in this piece, you can see more clearly, there's the palisades, just like you'd see at the root of a follicle. And this tiny little cluster of cells right here, those are going to be those stromal cells that are keratin negative. It's basically analogous to a papillary mesenchymal body pushing into this tiny little baby hair root that's trying to form but isn't quite able to. You can see the same thing right here. Those are the stromal cells that are analogous to the hair papilla, and they're pushing up right next to, hugging the basaloid stuff. And you can see again the kind of boomerang shaped cells down here wrapping around collagen, really nice for dermatofibroma. And one other real nice bonus in this case, look at these little bright red blobs. These are trichohyalin granules, what you see in the inner root sheath in the root of a hair follicle. So again, we're seeing multiple different aspects of the folliculosebaceous unit being recapitulated here, and this is induction phenomenon over dermatofibroma, a really beautiful example of what happens there. Okay, one last example, just because I couldn't help myself. There's a really nice example of induction, which is just growing some sebaceous lobules, so some benign sebaceous stuff. Looks like sebaceous hyperplasia almost, but it's centered right over a dermatofibroma. And here, let me leave it a little out of focus so you can see the refractile pink collagen bundles. You can see how there's tons of little tiny collagen here in the middle, and you can see the purple cells are wrapping and swirling around each individual bundle. That's so helpful for that early atrophic form, these small, really pink dermatofibromas. That's a really helpful pattern, and here's a closer look in focus where you can see that same pattern again. So nice example. If I just even have a little bit of this on a shave biopsy, that's enough usually for me to say this is probably dermatofibroma. And in this case, it was interesting, their differential was dermatofibroma versus sebaceous hyperplasia. So the answer was yes. Yes, you have both sebaceous glands and dermatofibroma. And it was benign, so everyone's happy. And there's some regular kind of epidermal hyperplasia over the DF. So nice example. Now let's look at some potentially trickier cases, okay? So here's a nice case. I wish, again, I could show it even lower power because it's an excision. I'm going to show you around the edges of it. It's an excision that was taken out by a surgeon all the way down into the fat, okay, around this nodule. So we don't often get to see dermatofibromas completely removed like this. And here's the patient. Sometimes it's hard to tell in the middle what their normal epidermis looks like. So go to the edge. This patient is a dark-skinned patient. You can see melanin at the basal layer. And this is their relatively normal epidermis. And as you go towards the middle, the redi get longer, longer, longer. And at the bottom, they start getting kind of flat and blunted like this. And in the very middle, they're again nice and long. And the pigment, even though the patient has dark pigmentation, the pigment is much more dense right here in the middle. Okay, so there's the epidermal hyperplasia that we see over dermatofibroma. Down here in the superficial dermis, you barely see anything. You see a little bit of that stuff I was just showing you underneath the sebaceous lesion, a little bit of tiny bundles of collagen getting trapped. So a good clue that you're at the top of a dermatofibroma. But this one, the center of it, is actually deeper in the dermis, okay? And from lower power, it again looks kind of like a little explosion happened here in the dermis, and it sent little fingers out into the dermis at the periphery on both sides. See, it doesn't have a smooth circumscribed border usually. It has a little jagged irregular border. And oh look, it goes into the subcutis. Now see, these are just like I showed earlier, these are these little rootlets of tumor just kind of trickling down a little bit, but you can tell this tumor is really centered right here in the deep dermis, or at the dermal subcutaneous junction in this case. There's a touch of fat trapped in the middle of it. But really, this is not a large infiltrative lesion that's destroying the subcutis and entrapping everything like a DFSP usually would be. But instead, this is just a dermatofibroma that's got a little bit of entrapment of fat where it interfaces with the subcutis. When you see bigger biopsies of dermatofibroma, this is actually a common finding. You will see this on a regular basis. This is not a rare thing. This is a common finding. So do not be concerned by that little bit of fat kind of getting entrapped into the edge. This is not the honeycomb entrapment of fat that you see in dermatofibrosarcoma protuberans. In the middle, the cells are a little bit storiform, and maybe in some short fascicles. But a good example of the fact that you can have fat involvement to some extent with dermatofibromas. Here's another example of that same thing. It's a much older slide, so it's very faded. I apologize. Oh, it might work out actually here. Let's see. Again, the dermatofibroma is centered in the deep dermis, but this one extends quite a bit into the subcutis, really pushes down into the subcutis. Here's another piece. It's upside down, but it really pushes down quite a bit, but it still has that shape where the center is right here and it's kind of exploded outwards and it left little jagged edges going out into the fat and into the subcutis. Now, if you were worried about this, you could do a CD34, which is usually going to be negative in dermatofibromas, okay? Some people like to use factor 13A, which will usually stain scattered cells or many cells in the background of the dermatofibroma. I personally don't find that very useful, but I know some people who do, and that's totally fine if you like that. The main thing is you got to be real careful with CD34, and I don't have an example to show today. I'll have to show that in another video, but CD34 can really strongly stain the periphery of the dermatofibroma, because 34 is positive in the normal dermis, and where the tumor kind of trickles into the dermis at the edge of the dermatofibroma, you can get this really heavy band of CD34 staining that makes kind of like a halo, a circle of bright staining around the edge of the tumor, but the middle of the tumor is usually dead negative except for the background blood vessels. So here's an example of what I'm talking about. You can see the dermatofibroma down here in the bottom corner, and then here's the dermis, and look, the dermis, it's maybe a little hard to tell from this power, but the dermis is pretty brightly stained with CD34. Look, the papillary dermis is negative except for the little vessels, but the reticular dermis has a lot of CD34 positive dendritic cells that are going to stain. So CD34 normally highlights the dermis relatively strongly. And you can see the dermatofibroma is distinctly negative. You can see little vessels in there, but the tumor cells are actually dead negative. But right here at this periphery, this interface between where the tumor interfaces to the dermis, you can see a halo or a band of more dense staining. And I feel that's where these CD34 positive cells are kind of colliding with the edge of the dermatofibroma and piling up there. That's what I imagine is happening. At least that's the way I remember it. So don't be surprised to see strong staining at the edge of a dermatofibroma. And look, particularly think if you had a shave biopsy just right through here. You could see that and say, oh, it's a CD34 positive neoplasm and get worried about DFSP. So you got to be familiar. I've seen that happen before on small biopsies where the 34 is relatively strong because it's just the periphery of a bigger, deeper dermatofibroma. So just recognize that this phenomenon happens on a relatively regular basis. Here's the other side of the same lesion. Again, look at that band. Very nice highlighted band of CD34 that's strong at the periphery of the lesion. The tumor in the middle is negative. A little bit of CD34 coming in here, but really it's negative aside from vessels. And there's a closer look again. Strong CD34. And look, there's a little bit of fat entrapment. So you see CD34 in the fat. Don't go down the tubes by thinking that means DFSP. The middle of the lesion is completely negative, and that's exactly what we would expect for dermatofibroma. So you just have to make sure you're careful. If you use CD34, you don't want to overinterpret it. Before you jump straight to that, though, look at the features and see if you've got other good features. So say you're worried about the fat entrapment in a case like this. You think it could be DFSP. And you want to know, well, how do I know if it's DF or not? Well, first, we can look, is there epidermal induction? This case doesn't have much epidermal induction or hyperplasia at all, actually. And I feel that the deeper dermatofibromas tend to have less epidermal change, which kind of makes sense. The farther they are down in the dermis, they don't always have as much epidermal change. So that clue doesn't really help us here. And we do have a little bit of collagen trapping at the edge. You sometimes can see collagen trapping in DFSP, not usually quite this dramatic as you see in dermatofibroma though. So collagen trapping, that's a good point towards dermatofibroma. In the middle, we can look and see if we can find some large plump cells, some scattered big cells. It could be a real nice clue towards dermatofibroma versus DFSP. And these cells are relatively plump. They're not the thin, stretched out spindle cells that I usually expect. There, that's good. Again, it's faded, but these are pretty big cells, right? They're kind of large histiocytoid cells. Some of them have nucleoli. Those are not the cells that you would usually see in a dermatofibrous sarcoma. Again, like I mentioned, it's a translocation sarcoma. It has uniform, monotonous, real thin, stretched out, thin, attenuated spindle cells, not plump, fat histiocytoid cells like you're seeing right here. So finding some cells like that is a really helpful feature. And if you're lucky, you'll find some giant cells. So giant cells are not always present, but sometimes present, multinucleated giant cells, sometimes laden with hemosiderin or sometimes foamy and Teuton-like. Those cells are really great evidence towards dermatofibroma and would be very uncommon to see in DFSP. And if you can find any pockets of blood or hemosiderin deposition or, again, foamy histiocytes, those are all features that help support the idea of dermatofibroma rather than DFSP. And in hard cases, you could do stains if you need. Okay, but try to start with the H&E first. It's usually an easier approach to it, and most of the time you can sort it out with a little experience. Now this is a fragmented specimen, but I think we can still glean some educational value from it. It's folded up here, but you can see that the epidermis, that's the normal epidermis. And then here in the middle, the epidermis is really, oops, the slide almost fell into the microscope, really thickened and hypertrophic, acanthotic. And it's not only acanthotic, but it has basaloid follicular induction right there, basaloid stuff. And this little area here, which is probably kind of either down a follicle or a flip tangential area, also has some basaloid induction. Very nice. So that's a good point towards dermatofibroma. Look at that beautiful collagen entrapment, big, thick, almost keloidal bundles of pink collagen being wrapped and entrapped by the tumor. Another point in favor of DF. Look right here in between those areas, and what do we see? Even though it's out of focus, you can see big, huge nuclei, a point towards dermatofibroma. A bunch of hemosiderin, another point towards dermatofibroma. So see here we've got all these features that can help us just by highlighting those few areas. Those features are strong evidence towards dermatofibroma rather than DFSP. These big plump cells, they got foamy and hemosiderin stuff in their cytoplasm. Some of them might be multinucleated giant cells. I know there are some around here, I just can't find them right now. The collagen trapping, the epidermal hyperplasia, the basaloid induction, all those things. And so it doesn't matter that there's fat involvement down here at the bottom. It's still a dermatofibroma because of all the features I just showed. So that's why it's important to recognize all these features, because they're really helpful clues to sort out what's going on. And yeah, here the tumor is trickling into the fat, but that's totally fine, and we see that at the base of dermatofibromas on a regular basis. And up here you can really nicely see the induction change of the epidermis. The hyperplasia, look at it, gets thicker and thicker. It starts tabling. You've got a sebaceous gland here. You've got really thick acanthotic stuff in the middle. Look, no Gren zone, huh? I told you, they don't always have Gren zones. This one is the dermatofibroma. There's a big artifactual space here, which is just from an artifact during cutting. But this tumor goes right up against the epidermis, and again, look at the basaloid follicular induction, really beautiful. And pockets of blood and hemosiderin, which are also strong evidence. I'll show later, I'll show an example of aneurysmal dermatofibroma, and you can see just how much blood and hemosiderin can be present in dermatofibromas, but also very, very useful clue, even when it's just focally present. Hemosiderin and blood strongly suggest dermatofibroma over DFSP. You very rarely see blood-filled spaces or hemosiderin or foamy cells in dermatofibrosarcoma protuberans. Those are much more common in DF and really rare in dermatofibrosarcoma. Okay, a couple other things to point out. Here's one example. This is relatively uncommon, but it does happen from time to time. This is a dermatofibroma that's completely centered in the subcutis. There is no dermal. It's all in the subcutis. So you might say, well, oh, how do we know it's a dermatofibroma then? Well, that's when we apply all the other things we've been talking about in this video and go look for those things. Do we have collagen trapping at the edge? We sure do. There's thick collagen bundles, and they're entrapped within the tumor. So very nice example of that. Here's more. Do we have hemosiderin? Absolutely we do. We've got hemosiderin right here. Great example of hemosiderin deposition. And we've also, if we move down just a touch here, not too much, you can see multinucleated giant cells, which also have hemosiderin. And look at the cells. Are they thin and stretched out? No, they're not. They're not like the cells of DFSP. They're big, plump, histiocytoid looking cells, kind of fat and variable in their size. Okay, they have nucleoli. You'll see scattered mitoses in dermatofibroma. All those things are great features for dermatofibroma. So again, the fact that it's in the subcutis and has some fat trapped in it doesn't matter, because there's no way this lesion that we're looking at right here could be DFSP. This has to be dermatofibroma, or maybe you could argue it's something else, but it can't be DFSP. Not in my experience. This is not what DFSP looks like. So finding all those features and applying them here, and then there's some hemorrhage. Here's some blood. Little areas, little pockets of blood bleeding into itself, another feature of dermatofibroma. So you don't see this very often, but you can occasionally see deep dermatofibromas totally centered in the subcutis, and rarely even you can see them in weird sites like the deep skeletal muscle. I've seen one in the larynx once. I would be very cautious before making that diagnosis again, unless you have got a lot of experience with soft tissue pathology. Even now, that still makes me nervous to see something that I think is a dermatofibroma, but in the middle of the quadriceps. I still feel uncomfortable with that at this point in my career. So that just to give you an idea of what how rare those are. They do happen, but they're quite rare. All right, here's the opposite problem. Here we have something that's too superficial. We got a tiny little shave. Clinically, it was ruled out nevus versus seborrheic keratosis. All the black stuff, if you're a beginner watching this, the black stuff is just surgical ink we put on there for the margins, so just ignore that. Here, all we have is very subtle elongation of the rete. It's really subtle, but you can tell kind of, even these rete over here are kind of blunted and flat on the bottom. Here the epidermis is a little bit acanthotic, but again, it's flattened on the bottom. So whenever I see that, even if I don't see anything in the dermis, I start wondering, could this be epidermal hyperplasia over top of a DF that's just not been sampled? The shave just wasn't deep enough. In this case, we don't have to just guess, we can actually know the answer, because look, even though it's so focal and tiny, those, I'm gonna leave the condenser on and out of focus for a minute here so you can see the pink collagen and the little boomerang-shaped dermatofibroma cells wrapping around and intercalating between the collagen. Really helpful. Even a tiny focus like this to me is enough in the right context, again, to make a diagnosis of dermatofibroma. So in this case, I just say dermatofibroma, comma, superficially sampled. When it's real thin, I like to let them know it's a dermatofibroma, but I'm only seeing a tiny bit of the lesion. So here is the opposite end of the spectrum, the really, really subtle, really tiny biopsy of a really subtle lesion, but still with practice, you can recognize that pattern of boomerang cells shaped, circling around the collagen, and that really subtle induction change, and you can get to the diagnosis of dermatofibroma, even though the biopsy is very small. So that's a nice trick to have and keep in your pockets. All right. That's dermatofibromas. I hope that's helpful to you. A good place to start, at least. I'll make some more videos about variations of DF in the future, as well as a DFSP video. Thanks for watching. Click like if you enjoyed this, and please subscribe to my channel.